So it's hemorrhage once again, and this time we are talking about the degree and the classification. Why is the degree and classification important? Because we have to categorize the type and the amount of bleeding so that the management can progress as we like. We'll talk about the estimation of bleeding. We'll see what are the various factors that need to be taken into account and how we can estimate the bleeding that is occurring. We'll talk about the HB levels, the hemoglobin levels, very important, talked about very commonly by the layman as well. And we'll talk about the hemorrhage quantification by HB level. And finally, we'll talk of the treatment of hemorrhage in a little while. So let's get into estimation and see how that occurs. So what is this figure? This figure represents gauzes. These are various gauzes that have been used in an extensive surgical procedure. Now, one of the methods of the estimation of blood, that is the bleeding that has been occurring during a surgical procedure, is by weighing of these gauzes. And by weighing of these gauzes, we get an idea of how much soakage that these gauzes have taken up, how much blood these gauzes have soaked, because these gauzes are initially dry and almost weightless. And once they absorb blood, they gain a lot of weight, and by finding the difference, by making out the difference, you can actually quantify the amount of blood that has been absorbed by these gauzes. So adults, they have approximately 5 to 5.5 liters of blood. So again, children and adults, they have 70 ml per kg of blood. So that is an approximation. So in neonates, the average is heights 80 ml per kg. It is difficult to estimate the blood. Now, why is that? For once, the bleeding is occurring actively and the bleeding is not occurring by your permission. So when the body is not prepared for something, you cannot actually quantify it. Secondly, the bleeding is occurring in the environment throughout the area. You cannot exactly quantify the amount of blood that is getting out of your body. So the bleeding is soaking your drapes. The bleeding is soaking your, for example, if it's a traumatic condition, if it's a roadside accident, the bleeding is contaminating your area. Yeah, the bleeding is contaminating your body. The bleeding is through your jacket, through your shirt, through your clothes. So you cannot actually measure the amount of blood that has been lost. It is an estimation. That is the reason we call it an estimated value. And this estimation gives us some idea of the amount of blood loss. And with that estimation, we try to resuscitate our patient. So whatever your estimate may be, it is always underestimated. What does that statement mean? So estimated, underestimated. So keep that in mind. Whenever you estimate bleeding, try to overestimate it. Why is that? Because a lot of bleeding has been occurred before. You have not seen, the bleeding did not start right in front of you. It has been occurring for a while, and you have to keep that in mind. So overestimation of bleeding is actually something you should keep in mind. You should always keep an idea that some of the bleeding has occurred that has not been seen by you. So you should keep that portion of bleeding in your mind and overestimate the quantity which you think. So again, in an external hemorrhage, the bleeding is pretty obvious. For example, I cut my finger, you can see the amount of bleeding that is occurring. So you can have an idea, all right, he has lost some blood. You can clearly see that in external hemorrhage. But then again, if that's a road traffic accident, that's an altogether different story. You cannot quantify the bleeding in a road traffic accident. You can say there was a lot of bleeding, but a lot of bleeding in my perspective and a lot of bleeding in your perspective might be different. So you cannot exactly quantify what was going on. It is difficult to estimate bleeding in a concealed hemorrhage. We've talked about concealed hemorrhage before. And in a concealed hemorrhage, what happens is you find you cannot actually see the bleeding. The bleeding is within the body cavity, and to measure that bleeding, it is very difficult. So in a concealed hemorrhage, it is pretty difficult to estimate the volume of bleed. So it is difficult to estimate the actual volume loss, be it external hemorrhage, be it a concealed hemorrhage. However, in operation theaters, the blood suction apparatus can be used to measure the bleeding. So the suction apparatus that is being used, it can also quantify the amount of blood that is being sucked out. However, again, in traumatic conditions, there can be a lot of debris in it, and the actual volume might be overestimated, or it might not give the right picture. Now again, the swabs soaked, here you can see these are the soaked swabs. They can be weighed, and with that, the amount of bleeding that has occurred in the body can somehow be estimated. So now the hemoglobin level. So hemoglobin level is the amount of hemoglobin that is present in the blood. So what are the normal acceptable ranges? So for females, it is approximately 14, and for males, it is approximately 14.5. In children, there's a range. Again, at birth, it's 16.5. That's a higher hemoglobin level. So at 1 month, it is 13.9. Then at 1 to 2 months, it's 11.2. At 2 to 6 months, it's 12.6. Up to 2 years, it's 12. It's from 2 to 6, it's 12.5, and from 6 to 12, it's 13.5. So these are the accepted levels. However, these are the mean levels. So there are ranges. You can range from the low, from low to high within the normal range. So these are the ranges that are important. You should always stay within the range for normal for your age. So it is actually a poor indicator of the degree of hemorrhage, and we'll see that because why is that? That is because it represents the concentration, not the absolute amount. So this is the concentration of hemoglobin in the blood. It is not not the amount of hemoglobin in the blood. So this is actually a poor indicator of hemorrhage. HB or hemoglobin level cannot be used as an indicator for hemorrhage. Now, in early stages, it usually remains unchanged. Now, why is that? Because the body is trying to compensate for the hemorrhage that has been occurring, and when the body is trying to compensate for it, there would be no changes in hemoglobin levels. So the hemoglobin levels would remain the same regardless of whether the bleeding has been occurring or not. And when the physiological mechanisms that were holding the body in place are lost, that is when the hemoglobin levels might fall, but that might be too late for you to do something. So the reason for this is that the whole blood is lost and later the fluid shifts. So what does this mean? So initially, when there's blood loss, the entirety of blood, the whole blood is being lost, not a segment of the blood. But when resuscitation attempts are there is fluid shifting from the intracellular environment to the blood compartment, to the transcellular compartment. And why is that? That is so the volume of the fluid in the bodily compartments might increase. So the intracellular fluid, it comes into the extracellular compartment and the vascular compartment, and with that there's shifting of fluid, and there is dilution of the hemoglobin level. Now again, we're talking about the intercellular fluids that are being transferred to the interstitial and the vascular compartment to compensate for the blood loss. So HB and the hematocrit level fall at this point in time. Now, moving on to the quantification. So, the hemorrhages can be classified according to the amount, the percentage of blood that has been lost. And with that, there are four classes from class 1 to 4. This is based on estimated blood loss. Again, we cannot quantify the blood loss exactly, but the estimated blood loss can be used to quantify the percentage of blood that has been lost from the body, and on the basis of that there are four classes. Now, initially, before this quantification, or before initially when the bleeding starts, the body tries to physiologically combat this bleeding. What does the body do? It forms a platelet plug. It tries to it calls for the fluid that is present within the cells, and this fluid is collected in the interstitial compartment and the vascular compartment, so that the volume of the fluid can be increased. So there are physiological mechanisms that are activated by blood loss, so that initially the body can compensate itself. However, once the compensation fails, the hemorrhage actually develops. So there's variation across ages and amongst individuals. So I might take hemorrhage one way, my body might respond to hemorrhage one way, and your body might respond to hemorrhage another way. Now, why is that? The compensatory mechanisms of the bodies are different. Every body has been trained in a different kind of way. For some people, their bodies are trained in such a way that they can undergo rapid blood loss and still withhold their condition. However, with some patients, a slight blood loss might be dangerous. Again, at the same time, a younger individual can easily compensate for some blood loss. However, an older or a relative or a very young, a neonate, cannot compensate blood loss very well. Now, there's difference due to confounding factors like concomitant medications. So that is very important. Patients on various medications tend to increase or decrease their bleeding, their hemorrhage. So various medications might prompt hemorrhage, and various medications might be helpful against it. So patients undergoing polypharmacy, patients taking a lot of medication, they have complicated histories and complicated responses to hemorrhages. So the classes of hemorrhage we were talking about, there are four classes based on the percentage. In class 1, less than 15% of the blood volume has been lost. In class 2, 15 to 30% of the blood volume has been lost. In class 3, 30 to 40% of the blood volume has been lost. Class 4 is severe hemorrhage, in which more than 40% of the blood volume has been lost. So these are some of the classes that are commonly used to quantify bleeding. So again, the young, they compensate well, the old, they compensate poorly for obvious reasons. The young have sufficient reservoirs, supple vessels, and their bodies are in their prime. However, with older individuals, they're on polypharmacy, it's difficult for them to compensate. So this is that. Now, treatment, the management, let's talk about it. So it is based on the degree of hypovolemic shock. So let's say if a patient is in first class of hemorrhage, that is less than 15% of blood has been lost. So the management would be vigorous, but not very vigorous. You would try to compensate for that by fluids, by resuscitation, and you would try to stop the bleeding. However, in a class 4 patient, in a patient who has lost more than 40% of the blood volume, what would you do? You would try to manage your patient aggressively. You'll take your patient to the surgery straight away. You'll try to clip the bleeder that has been that is there, the bleeder that is causing massive bleeding. Would try to resuscitate at the same time. Would be massive transfusion protocol activated, and a lot of blood would be, or the blood products would be transfused to this patient to save the patient. Now, while you're doing that, assess the vital signs of the patient. It's very important that a patient might not be a goner. You have to make sure that your patient is still surviving. A patient who's brain dead would not respond well to resuscitation. A patient who has lost, a patient who has died, unfortunately, due to trauma that occurred at a roadside, would not respond to your resuscitation. So it's very important to check for the vital signs. It is very important to check for the preload and the base deficit. Again, these help you to manage your resuscitative attempts, and you should always have an idea of that. Now you should see the response to fluid therapy. Now this is very important, the dynamic fluid response. This is very important. So what happens, you give fluid to the patient and you check for the response of the patient. So the non-responders or the transient responders are the ones who are still bleeding. So these are the ones you need to look out for. These are the ones that are still bleeding, and you need to stop those bleedings. With once the bleeding will be stopped, then the resuscitation attempts would help. Now the identification of the hemorrhage site in these patients and control of the hemorrhage site is very important. That is the keystone. If you identify and control the hemorrhage in these patients, in these non-transient responders, you can make them responders. So dynamic fluid therapy, very important. Again, the response to dynamic fluid therapy, even more important. So that is how you manage your patient. So this was all about this section. In this section, we took the practical aspects of bleeding. We saw how the management of bleeding goes. I hope you liked and understood this section. For further sections, keep watching sqadia.com.